Hi, very good morning. I'm Dr. Janak Patel. I'm MD physician. I'm not an endocrinologist. Whatever I've gathered from internet and from slideside.com, I'm sharing with you. I'm going to talk today regarding a male hypogonadism. Meaning is very simple. Decreased function of gonads. The main function of gonads is to produce testosterone, and second function is spermatogenesis. So when these two functions is affected and their function becomes poor, we call that as a male hypogonadism. We'll be discussing under this heading as routine. So definition of hypogonadism means decrease in either of the two major function of the testis, that is spermatogenesis or testosterone production. Very simple definition. So either it is a failure of gonads itself or it is a failure of hypothalamic pituitary gonadal axis. Even if this is affected, the testicular function will be affected. So hypogonadism is a clinical syndrome that results from failure of testes to produce physiological level of testosterone, that is androgens, and normal number of spermatozoa due to disruption of one or more level of hypothalamic pituitary gonadal axis. When it is involvement of the testis as a primary, we call it a primary hypogonadism, and when there is involvement of hypothalamic pituitary gonadal axis, then we call that as secondary. So we'll have two varieties. So hypogonadism is decreased function activity of gonads, and male hypogonadism means specifically of testis, which is producing androgens and sperms. When both are affected or one is affected, we will call that as hypogonadism. So we already mentioned male hypogonadism is a clinical syndrome because of deficiency of androgens, and because of deficiency of androgen it can have an adverse effect on multiple organs, and it will affect the quality of life, while spermatogenesis defect will produce infertility only. No other symptoms will be there except infertility. So this will be the male hypogonadism. There is something called as a late onset hypogonadism, or short form it is called LOH, meaning it is a syndrome associated with advancing age and characterized by typical symptom. This is very important. As the age advances, you start getting a symptoms of hypogonadism, and that is at the late onset, means in an advancing age. There is a deficiency of testosterone level and may result in significant detriment in the quality of life and adversely affecting the multiple organ system also. So it is a deficiency of androgens in advanced age. It is not andropause, but it is a late onset of hypogonadism. In a primary hypogonadism, the testis is not functioning. There is something what has happened to testis. Either it is a damage to the testis, or it is a genetic defect or an acquired defects. It will produce decreased production of testosterone or spermatogenesis or both. But in that, hypothalamus, pituitary, gonadal axis is working, but gonads are not working, and that we call as a primary. In that, you will have a gonadotropic level, may be normal or may be high. So it is called as a hypergonadotropic hypogonadism, and that is primary. While in secondary, there is something what has happened to either hypothalamus or to pituitary, and because of that, there is a decreased production of gonadotropics, and that's why it is called hypogonadotropic hypogonadism. Very, very easy to understand. because there will be decreased production of what we call as a gonadotropic releasing hormone. So it will be because of hypothalamus, which will have effect on anterior pituitary, and there will be decreased production of FSHLH, we call as a decreased gonadotropic hormones, and that's why it is a common term utilized for either pituitary or hypothalamic induced. We call as a hypogonadotropic hypogonadism, and that we call as secondary. So it can be primary, it can be secondary, or sometime it is because of androgen insensitivity, or we call as a and organ resistance. So these are the three varieties which are commonly being described. Primary, basically testicular failure. Secondary means hypothalamus gonadotropic or hypothalamo pituitary gonadotropic axis involvement, and androgen insensitivity or and organ resistance, or there is a resistance at the level of androgen receptor. We call that as androgen insensitivity. So this will be the three conditions. Now primary can be combined androgen with sperms or isolated sperm production, etc., which can be congenital, acquired, or because of systemic effects. So primary can be because of congenital, acquired, or systemic. Secondary can be also because of congenital, acquired, or systemic. So let us go through etiology. Basically, we divide into these two big groups, and third group we call as a peripheral resistance, or resistance at the level of we call as a androgenic receptors or testosterone receptors. So primary is because of testicular causes or because of receptor disorder, and secondary is because of hypothalamus or pituitary axis. Can be congenital, can be acquired. So these are all the different causes of congenital, and these are all the different causes of acquired hypogonadotropic hypogonadism, and this will be because of what we call as a hypothalamo pituitary axis involvement. It is hypogonadotropic, so it has to be either hypothalamus or pituitary induced. We'll be dealing with some of the common causes. We don't go into detail. So in a primary hypogonadism, you can come across Klinefelter syndrome, which is called XXY or triple XY, which is because of one additional X chromosome, or you can have a XX male, which is called sex reversal, or you can have a Noonan syndrome, which is a male Turner syndrome, which is 46 chromosome, which is having an abnormal gene presentation as 46XY. It can be autosomal dominant, myotropic dystrophy, myotonic dystrophy, or there is one syndrome called as a vanishing testis syndrome, or called as a congenital anorchia. There is an absence of testis, which is again related with 46XY chromosome, which is also called as a male Turner syndrome. Or you can have again, there is another which is common with this 46XY chromosome abnormality called Sertoli cell only syndrome. So these are all genetic causes which is responsible for primary hypogonadism, while acquired variety is very commonly because of cryptorchidism. The testis has not descended into the scrotal part. It remains either in the inguinal canal or maybe even in abdomen, and there will be acquired germinal cell aplasia, or testis is destroyed because of orchitis like mumps, or because of trauma, or because of radiation, surgery, diabetes, etc. Or there can be disease like chronic kidney disorders, cirrhosis, HIV, certain drugs, particularly opiums, alcohol, we call XRT, that is glucocorticoids, etc. So these are the drugs which are being used in HIV, etc., and they can produce damage to testis. So these are some of the disorders which are acquired groups, some of the common disorders. So you can have a congenital variety, classical Klinefelter syndrome, congenital anarchia, which is 46 XY chromosomes, or peripheral androgen receptor resistance, or we call enzyme defects. So this will be congenital group. Even Noonan's, Mail-Turner, etc. will be in that group. Among acquired, testicular damage by trauma, injury, surgical removal, orchidectomy, or by chemotherapy, or by irradiation, or maybe damage because of mumps. Common, these are the most common. Or maybe secondary due to diabetes, CKD, cirrhosis of liver, etc. So these are some of the primary causes like Klinefelter, Hypogonadism. So it is either in the inguinal canal or maybe in the abdomen. Or one of the another causes secondary due to mumps or chitis. Maybe because of chemotherapy, or maybe because of radiotherapy, or maybe infiltration of testes by hemochromatosis, and you can have a bilateral testicular damage. Even opiums can produce damage to testes, and obesity can also have a decreased testosterone production. Secondary causes of hypogonadism, which is congenital. Very commonly, it is a Kallmann syndrome or isolated hypogonadotropic hypogonadism, very rare. Or there is a mutation in FSH-LH mutation, or there is a leptin receptor mutation, gonadotropic receptor mutation, or there is a pan-hypopituitarism, or there is a one adrenal cause we call congenital adrenal hyperplasia, which is because of 21 hydroxylase enzyme deficiency. These are some of the conditions which are not affecting primarily testis, but it is secondarily affecting testis because of decreased production of which stimulates testis. So these are some of the conditions. In this particular, that is we call congenital adrenal hyperplasia, you will have a decreased production of androgens from adrenal gland and may be associated with hypogonadism. So these are congenital conditions for secondary groups, which is outside the testis. And this is acquired group in secondary. Hyperprolactinemia, which is very common in female rather than male. GNH-RH analog therapy, because this is given as a treatment in some of the conditions. Person who is on a glucocorticoid therapy, a person who has got a critical illness or a chronic critical illness, diabetes mellitus, opiums, pituitary tumors, which can end up with panhypopituitarism, infiltrative disease which is involving pituitary or hypothalamus, or person has undergone surgery or radiotherapy for pituitary, even example like hemochromatosis, etc. And this might maybe mixed variety also, where you can have simultaneously also involvement of testis. But this will be some of the condition which will be other than testis, and then we call that as a secondary hypogonadism. But all these are acquired groups, so that is put into acquired groups. I'm skipping over this. There are a lot of secondary causes like stress, systemic illness, pituitary tumors, prolactinomas, then drugs like anabolic steroids, or person who is on cocaine or person who is cocaine addicts, opium addicts, drugs causing hyperprolactinemias, hemochromatosis, Cushing syndrome, prolactinomas, all these Prader-Willi syndromes, Lawrence-Moon-Middle syndromes, these are genetic groups which can also have secondary hypogonadism. I'll skip over this particular slide also. These are some of the persons known to have a high risk of hypogonadism. These are all what we have already mentioned. There is one more which is being added here, is person who is on a hemodialysis, end-stage renal disease with hemodialysis. Even in a person with a chronic obstructive lung disease also can develop. This is all because of a chronic disorders. Chronic disorders. In a fracture skull, craniopharyngioma, sarcoidosis, tuberculosis, anorexia nervosa, constant stress also can produce secondary hypogonadism. These are pituitary induced causes, hyperprolactinemia, empty sella syndromes, etc. So pituitary tumors can end up with panhypopituitarism and can be associated with secondary hypogonadism. This is one variety which we already mentioned, androgen insensitive syndromes, or we call the male hypogonadism due to defect in the AND organs, androgen target organs, which are AND organs, or we call as a androgen receptor resistance or insensitivity. This is that what we call as a AND organ resistance. And one of the another variety we call as a Mori syndrome, which is a androgen insensitivity syndromes, which is male karyotyping, female phenotypings. This is genetic because of XXY chromosomes, and there is a male level of testosterone, but there is an insensitivity to the receptors which are present at different levels. I've already mentioned regarding late onset hypogonadism, that is a clinical syndrome which is biochemical syndrome associated with advancing age, and there is a typical symptoms because of deficiency of serum testosterone level, and usually it is between the age 39 to 70 years. The free testosterone level which goes on declining 1.2% per every year, and there is a albumin bound testosterone by 1% per year, and there is a sex hormone binding globulin also starts getting affected, and this will also alter what we call as a free testosterone level, and that will give rise to what we call as hypogonadism because of decreased testosterone level with advancing age, and then it is called as a late onset hypogonadism, when the testosterone level becomes so low that person start getting symptom signs of hypogonadism. As far as pathophysiology is concerned, very simple to understand. If anything which produces damage to hypothalamus or pituitary, or it is any other factor outside, say like adrenal gland, then we call that as secondary, and that will be very frequently associated with normal level of gonadotropic hormones or elevated level of gonadotropic hormones, and testis function is affected because of those particular hormones. Sorry, that will be in secondary, so testis is affected, so testis do not produce what we call as testosterone, which is produced by Leydig cells, and Sertoli cells do not produce sperms, that is spermatogenesis, then we call that as a primary, where pituitary function and hypothalamic function may remain normal, and you will have a normal production of a gonadotropic releasing hormone, and you will have a normal production of FSHLH. So you will have a normal production of a, or increased production, because there is no negative feedback, so there will be increased level of GNHRH or FSHLH, and that will be typical in a primary variety. In secondary variety, you will have a decreased production of GNHRH or decreased production of FSHLH by pituitary, then we call that as secondary. So that's why it is called as a hypogonadotropic. Hypogonadism is secondary, and also it can be because of secondary due to adrenal gland, very classical in case of a congenital adrenal hyperplasia, where you have got a decreased production of a glucocorticoid, mineralocorticoid, and you have got an excess production of androgenic hormones, and that can lead to hypogonadism. So this is that GNHRH production. You will have a testis which will produce testosterone, and that will be produced by Leydig cells, which will have effect on all these characters, that is male character, secondary sex characters, libido, aggressions, voice, brain, and all the structure, muscles, bones, etc. But testosterone will inhibit GNHRH. So whenever there is a normal production of testosterone or increased production, it will inhibit GNHRH and it will inhibit FSHLH. But whenever there is a decreased production, this inhibition is not there. So there is constant production of GNHRH and you will have a constant production of FSHLH. So those two level will be normal or maybe elevated, and that will be in a primary variety. So in a primary variety you will have a hypergonadotropic hypogonadism. There is one hormone which is released by what we call the Sertoli cells, which is called inhibin, and another is activin. Activin will stimulate, inhibin will inhibit. So inhibin will inhibit GNHRH and GHHRH, while activin will stimulate. And FSH-LH, LH will stimulate Leydig cell and FSH will stimulate Sertoli cells. And Sertoli cells will have a spermatogenesis. So this will be the normal. So if there is anything happening at this level, we call as secondary groups, and anything which is happening at the testicular level, we call that as a primary group. So very simple, the testosterone metabolism, testosterone will be further metabolized into a breakdown products by liver. So it is secreted out, it is manufactured from cholesterol in testis as well as in adrenal glands. In testis it is manufactured by Leydig cells, in female by ovary, and in male and female by adrenal glands. And in adrenal gland we call them as androgens. And for manufacture of that you don't require 21 hydroxylase enzyme. But for conversion from cholesterol into pregnenolone and then pregnenolone into mineralocorticoid and glucocorticoid, you require 21 hydroxy enzymes, 21 hydroxy converting enzymes. And this particular estradiol will be acting on estrogen receptor and producing the effect. And testosterone will be combining with testicular, or we call androgen receptor, and will produce the effect. But when it enters into the bloodstream, it will combine with sex hormone binding globulin, as well as it will combine to receptor. So the free testosterone will combine with receptor. A small quantity also combines with albumin, and this will be the way it will be entering into the bloodstream. And then it will be broken down by 5 alpha reductase enzyme into dihydrotestosterone. And this dihydrotestosterone has still good effect on external genitals, prostate growth, acne, body hair growth, facial body hair growths, scalp hair loss, etc. And testosterone 90% is excreted out. 10% will be in an active form, and that will be further metabolized by 5-alpha reductase and aromatase enzyme, and that will convert that into estradiol. And that estradiol in a male also will have a bone resorption, epiphyseal closure, it can produce gynecomastia and some vascular and behavior effects. While testosterone itself, which remains in an active form, will have effect on Wolffian duct, bone formation, muscle mass, spermatogenesis, etc. So this will be the way. 50 to 70% is attached to albumin, 30 to 45% is attached to what we call the sex hormone binding globulin, and only 0.5 to maximum 3% remains free in blood, and of that part will be converted into dihydrotestosterone, part will be converted into estradiol, and that percentage is very small, 0.3%. But when this increases, it will start producing what we call as feminization. And rest remains active as testosterone. So maximum 5 milligram remains in an active form of that secreted amount. This is metabolism and action of testosterone and metabolic products. So this is that what we have shown you. 60% is bound to sex hormone binding globulin, 38% to albumin, only free is 2%, average is 2%, and that is active form, and that will be metabolized into different products, dihydrotestosterone, estradiol, and free as testosterone, which will be acting at the different level at skin, male sex hormones, sex organs, secondary sex organs, brain, bone marrow, bone itself, muscles, etc. This is the main function of testosterone. I'm not going into detail of that particular part because that we have already discussed in androgens. And this is that what we call as a hypothalamic pituitary testis axis, which we have already shown you before. So this is same. And so in a primary hypogonadism, testosterone level is low, but LH level we call as a gonadotropic level, which is secreted from anterior pituitary, will be high, normal or high. In secondary, if it is because of pituitary tumors, pituitary dysfunction, then LH level will be low, FSH level may be affected, may not be affected. So usually FSH LH level will be low, and because this is low, it does not have action on testis, even testicular level will be low. While in a hypothalamic, GNHRH secretion is decreased. Because GNHRH secretion is decreased, there will be decreased level of FSH-LH. So we will have a decreased level of GNHRH, decreased level of FSH-LH, and also decreased level of testosterone. When all the three are affected, releasing factor, gonadotropic hormones, and testosterone, all the three are low, going in the same direction. It will be hypothalamic induced. If GNHRH remains normal, FSH-LH is low, testosterone level is low, pituitary. And if LH level is high, testosterone level is low, testicular induced. Classical example of testicular, Klinefelter syndrome, Turner syndromes, etc. While in case of hypothalamus, Kallmann syndrome. And in pituitary, local destruction of a pituitary gland by either tumor, radiation, surgery, infiltration like hemochromatosis, etc. So that is the main difference we have already explained. So this is a simple thing which we call as an increased production of GNHRH, increased production, but testis is not working. So testosterone level and spermatogenesis is decreased, and this is a typical because there is no negative feedback, because there is no secretion of testosterone. So testosterone cannot inhibit, and that will result into low level of testosterone and increased level of GNHRH and FSH-LH. Classical example. But if there is decreased level of GNHRH in this, then it is hypothalamic induced. If it is GNHRH level is normal, but FSH level is reduced and testosterone level is also reduced, it will be pituitary induced. Pituitary induced. In pituitary induced, LH, FSH level will be low, testosterone level will be low, GNHRH level will be normal or maybe elevated. That is typically secondary hypogonadism, which is pituitary induced. And this is late onset, where testis, there's a decreased testosterone production, increased sex hormone binding globulin, so there is a less quantity of free testosterone, because of which there is a stimulation of hypothalamus and pituitary. FSH LH level is increased, so you will have both things together. Because of decreased testosterone level, there is an increased stimulation, no negative feedback. So hypothalamus and pituitary goes on secreting GNH, RH and FSH LH. This is a mixed variety we call as a late onset hypogonadism. These are some of the factors which can also have effects. I'm skipping over one of the component in metabolic syndrome because of obesity, diabetes, and depending upon the age of onset, you will have a different symptoms and signs. So if it is in infant before birth, then child will be born with sexual ambiguity. If it is before puberty, puberty does not progress, we call as a delayed puberty. If it is after puberty, then infertility and sexual dysfunction like decreased libido, etc. So we'll be going through that. This is classical sexual ambiguity. You will have no male or female characters, and you will have a delayed puberty, classical example, and After puberty, infertility and sexual dysfunction leading to lot of symptoms and signs. This is because of the fetal development. Female genitalia will be ambiguous genitalia. You will have neither clearly male nor a clearly female. Underdeveloped male genitalia. This will be in a female, this will be in a male. And that will be typical if it is during fetal development. So, in an ambiguous genitalia, you will have a pseudo vagina. You will have a pericoscotal hypospadias, microphallus, cryptorchidism, and bifid scrotum. This is a typical characteristic of a ambiguous genitalia. If it is before puberty, this will be the character. If it is after puberty, this will be the character in a male. Before puberty, testis size will be very, very small. Penis size will be small. High pitch voice. Inocoid stature. Gynecomastia. Central fat distribution. Decreased body and facial hairs. And delayed bone age. While if it is after puberty, testis volume may remain normal. Maybe slightly reduced. Normal penile size. Voice will be broken. Normal body proportion. There will be gynecomastia, normal hair distribution but poor growth, and person will now start developing what we call as osteoporosis. This is pre-pubertal, delayed puberty. What it will be have? Loss of libido, reduced night times or morning spontaneous erection, reduced motivations, diminished strength, physical performance, breast development, that is gynecomastia, no sperm formation, no spermarche, and infertility. And this will be very typical in a pre-pubertal. And during puberty, gynecomastia, decreased development of muscle mass, lack of deepening of the voice, impaired body hair growth, impaired growth of the penile size, testicular size, excessive growth of the arms and legs, relation to the trunk and body, and gynecomastia. This is typical signs of what we call as a inner puberty person after puberty because of androgen deficiency, small testes, infantile genitalia, loss of male hair pattern, disproportionate, long arms and length is relative, long arms and legs compared to height, adult low bone mineral density. All this will be seen in that particular. And you can have also psychological symptoms, lot of psychological symptoms because of decreased libido, etc. These are all those symptoms because of testosterone deficiency, emotional disturbance like depressions, reduced well-being, poor concentration, poor drive, and general body effects will be decreased muscle mass, decreased muscle power, abdominal obesity, libido, loss of libido, hot flushes, palpitation, decreased body hair, anemia, and you can have a complication like osteoporosis, dyslipidemia, insulin resistance, sarcopenia, respiratory system, reproductive system will be affected, infertility or subfertility, decreased size of genital organs, loss of pubic hair, erectile dysfunction, sexual dysfunction, etc. Lot of things will be seen. This is a typical scene in a children, pre-puberty. Small size, gynecomastia, slow growth, decreased muscle mass, etc. Small size testes, lack of scrotal pigmentation, small size penile size, loss of pubic hair, no axillary hair, terminal hair growth is less, erectile dysfunctions, all those things will be seen. And along with that, decreased sperm count, anemia, reduced libido and activity, depression, gynecomastia, all those will be seen together. These are effect on musculoskeletal, we have already mentioned, sexual characters, mood, cognitive functions. Person can have insomnia, nervousness, depressions, lack of motivation, irritability, lethargy, lot of symptoms and signs which is affecting because of decreased sexual activity. and loss of libido, etc. Vasomotor symptoms like hot flushes, sweating, physical signs like diminished muscle mass, diminished muscle power, gynecomastia, abdominal obesity, loss of hairs, testis size is small. This is diagrammatic representation. A person will not be having a good muscle power. So do think of that hypogonadism. Typical gynecomastia with what we call as obesity, erectile dysfunction, infertility, failure of puberty development. Person can develop male menopause or we call andropause, etc. These are all mild to severe. In a severe variety, all this will be seen. In a mild variety, usually some of these symptoms will be seen. You can go through your at leisure time. This is classical Klinefelter syndrome, where you get a tall stature, feminizing characters, mild impair in IQ, loss of chest hair, female type of pubic hair, small testis, small penile size, osteoporosis, gynecomastia, poor facial hair growth, and baldness. Frontal baldness is absent because testosterone secretion is less, so no baldness. So this will be the typical characteristic. And you will have a karyotype XXY, typical. That is, you will have a, if you do a karyotypes, you will have a XXY in a Klinefelter. This is in Kalman syndrome, which is a hypothalamic disorder, congenital disorders, where you will have a rare genetic disorders characterized by delayed or absent puberty. Incidence is 1 in 10,000. Affects more male than female. Risk of strong family history. Usually there is a inability to produce a hormone by testis because of decreased production of GNRH. The symptoms are very peculiar. There is a simultaneous effect on smell, that is impaired smell, olfactory nerve is involved, small penile size, and undescended testis. This is usually we called as a triad. Along with cleft palate, secondary sexual characters are not developed completely, and testosterone levels is very low, and genetic karyotyping, if you do that, there will be abnormal X chromosome, Kalman syndrome. This is typical Kalman syndrome. Features are nearly same like as the person grows. Features will be nearly same, closer to Klinefelter. This is Prader-Willi syndrome, where the chromosome number 15 is abnormal, and person will have infantile hypotonia, obesity, crypt orchidism, short stature, mental retardation. These are that seen in that particular Prader-Willi syndrome. Typical features. If you are interested, you can go through at your leisure time. This is Noonan syndrome, that is autosomal dominant variety. It is one of the variety of a Turner syndrome, where you can have a abnormal ear, congenital heart defects, epicanthal fold, short stature, webbed neck, crypt orchidism, primary hypogonadism, etc. and can affect both. This is Turner syndrome, this is Noonan syndrome. You can have also effect because of opium on testis production, because opium can reduce release of GNRH, LH and testosterone. So can have, so a chronic consumption and opium alkaloids can. There is what is called as a reverse syndrome or reverse male, XX male, which is very rare. where part of the Y chromosome, there is a translocation with the X chromosome, and it is almost similar to Klinefelter syndrome, where it is XXY, and very commonly they will have a short stature and hypospadias. We already discussed regarding hypogonadism in an aging male, where you have got a male menopause, male climacterics, andropause, androgen hormone starts decreasing, and then it is also called as androgen decline in aging male, or short form it is called ADAM, ADAM, and aging male syndrome, also short form called as AMS. These are all the different names. Nowadays they utilize late onset hypogonadism. Investigation, mainly what you have to do is history, past medical history regarding chronic illness, head injury, testicular damage, radiotherapy, chemotherapy, etc. Have a good physical examination of external genitals. Look for sexual character, secondary sexual character. Look at a person as a whole. Take a good history, whether the person is on some drugs or a drug abuse like alcohol, opium, cocaine, etc. This can produce hypogonadism. Whenever you want to assess the testosterone level, it should be between 9 a.m. and measure 9 a.m. testosterone on two different occasions, and testosterone level can be affected by CKD, congestive heart failure, respiratory and COPD, cirrhosis of liver, obesity, metabolic syndromes, drugs like thiazide, opium, psychotropic drugs, amiodarone, etc. can also affect testosterone level. So you should keep this thing in mind. Get a good history, and this should, if these are present, your testosterone level will be affected. Invariably you will have a low testosterone level. Along with testosterone level, you need to measure free testosterone level, and in that free testosterone level, by and large, usually you measure a free testosterone level, FSH-LH level, to find out primary or secondary. So by and large, you measure the testosterone level between 7 to 11. If testosterone level is more than 12 millimole, then it is less likely to be hypogonadism. It is an alternative diagnosis, maybe some other etiology. If it is less than 12, then repeat testosterone level again, measure the level of FSH-LH, prolactin, etc. Because this will be affected in pituitary induced and hypothalamic induced. So try to estimate that level and try to find out if the person has got decreased level of FSH, LH and testosterone, it is because of pituitary induced. If GNH, RH, FSH, LH and testosterone level is reduced, it is hypothalamic induced. So try to estimate that, and you can find out whether it is primary or secondary. In a primary variety, testosterone level will be low, FSH level will be high, elevated. That will be very easy to differentiate the two. This is that same chart which is being showing you the morning level you should do, total level you do, or you can do also free testosterone level. And if it is abnormal, low level, you estimate FSH-LH level. Try to find out whether primary or secondary. If testosterone level is normal, have a good follow-up. If there is a normal testosterone level and FSH level is also normal, less likely to be hypogonadism. So you can have a regular follow-up. And if you want to differentiate the two variety, you will have to estimate what we have done before, and then you can go for a karyotypings to find out Klinefelter syndrome or Kalman syndromes. And in some conditions you can have even hyperprolactinemia producing hypogonadism. So particularly in female, go for prolactin level also. Even in male also you can have sometime secondary hypogonadism secondary to prolactin level. And once you suspect pituitary and hypothalamus, you may go for what we call as a CT MRI to find out pituitary tumor or hypothalamic tumor producing pituitary damage leading to hypothalamic pituitary gonadal axis dysfunction. So this is same thing at your leisure. You can go through what we have shown you before. Same, you can go at the primary hypogonadism, then you can go for Klinefelter syndrome and other testicular investigations. In secondary, you can go for prolactin level, iron levels, other pituitary hormones. You can go for CT, MRI, etc. to find out the etiology. Once you confirm the diagnosis of hypogonadism, you have to restore back the physiological testosterone level, mainly by hormone replacement therapy. You want to decrease the symptoms because of androgen deficiency. In that also, hormone replacement therapy will be useful. You want to restore back the physiological function, and you want to prevent long-term effect on a health because of androgen deficiency. These conditions, that is libido, decreased libido, if you want to reverse back the virilization in female, you will have to replace that particular hormone, but you will have to keep a watch between a well balance between side effects of testosterone replacement. If any person who has got osteoporosis, again you will have to replace hormone replacement therapy along with even estrogens. Normalizing the growth hormone level in elderly male, again you might have to replace growth hormones. A person who is at a risk of a cardiovascular disease secondary because of testosterone deficiency, again you will have to think it over and give hormone replacement. And in a person with infertility with hypogonadism secondary due to hypogonadotropic, you will have to give gonadotropes to increase gonadal functions. So this is the basic goal what we have mentioned before. So basic therapy, androgen deficiency will be treated by hormone replacement, and to maintain the sperm production you will have to use other methods also. As far as androgen deficiency is concerned, hormone replacement can be done by parenteral, transdermal or transbuccal. And to initiate and increase spermatogenesis, you will have to initially stimulation is done by testosterone and sperm production is increased by using human chorionic gonadotropic hormones. And you can use also what we call to stimulate the sperm production by GNHRH, using GNHRH, or you can add to human chorionic gonadotropic to stimulate the sperm production by using FSHLH groups. You can use any one of those groups, FSHLH productions. So this is a treatment of what we call as hypogonadotropic hypogonadism. You can use testosterone, transdermal patch, testosterone gel, buccal. You can use how much quantity to be given by using a serum testosterone level and observe the desired effects. There are some absolute contraindications for testosterone therapy if a male has got a breast carcinoma, prostatic carcinoma, BPH. There is an abnormal digital rectal examination showing you suspicion of a prostatic BPH or BPH carcinoma, prostatic carcinoma. There is an elevated level of PSA. Age is more than 80. If a person is on a psychopathology, sleep apnea, or if a person has got congestive heart failure, diabetes mellitus, CKD, liver tumors, chronic liver disease, etc. Or person has got a hypercoagulable stage, or person has already developed polycythemia and hematocrit is more than 51. In all these conditions, use of testosterone should be restricted. By and large, it is contraindicated in breast carcinoma, prostatic carcinoma, absolute contraindication. In other, you can decide depending upon the clinical conditions. These are all the different types of testosterone preparations. If you are interested, you can go through your leisure time. There are newer formulations which are available, very easy to give, like buccal, transdermal, sublingual buccal, and what we call as, this is under a clinical trial. Now it is available. While giving a testosterone, you should monitor certain things like prostate examination, hematocrit, hemoglobin, blood lipids, liver functions, and adverse effect of testosterone like gynecomastia, acne, priapism, sleep apnea, oily skin. So always look for side effects and examine all those things. And these are a lot of things which are there to be monitored. So look at erythrocytosis, hypertension, congestive cardiac failure, weight gain, obstructive sleep apnea, acne, gynecomastia, what we call is a PSA level, and even testosterone level. You should look for. These are the effect of testosterone excess replacement in an aging male. You can see the muscle mass will improve, but these are the complications. So you should look for testosterone side effects. These are all side effects of testosterone. So it stimulates the prostate tissue, gynecomastia, increases the risk of blood clot, sleep apnea, decreases the testicular size, increases chance of a myocardial infarction and strokes, etc. Also, there will be increased risk of polycythemia, dyslipidemia, sleep apnea, BPH, prostatic carcinoma, cardiovascular complications like MI, or even strokes. So I end my lecture here. I hope this lecture will be very helpful to you. You will see sometime once in a while a person with a hypogonadism. Try to identify whether it is primary or secondary. Usually in secondary the results are good. While in primary, if there is a complete destruction of testis, the testicular function cannot be recovered. You will have to use hormonal replacement therapy for lifetime. So these are some of the things regarding hypogonadism.